starting right now. And on behalf of the Chamber, Connecticut River Valley Chamber, I want to welcome you after a nice long holiday weekend. And this morning we have Dr. Joseph Cappa from Connecticut GI and Dr. Brian Chiffer, who is a dentist, both doctors in Glastonbury, who are going to share some information with us about how they are making their practices safe for us to return back to our routine medical and diagnostic testings. And we all know that we're all very concerned about returning back to normal, whatever that is. And so both doctors, I thank you very much for your time today. I know you've reorganized even your patient schedule to be with us. So we appreciate that. It's very important to hear from you. And with that, Mike Ski is our facilitator, and we'll just open it up.
That's great. Thanks. Thank you, Mary Ellen, and welcome again, everybody. Just a quick reminder so everybody knows the sessions we do during the week. Today's topic, Tuesdays, every Tuesday at 9 a.m. we do a different topic. Thanks to Tina and Mary Ellen, the Chamber team, for keeping those ongoing and getting people scheduled to showcase for us, and we can learn from all of them. They've been great. On Wednesdays at noon, we do a virtual hug for just networking and developing relationships, kind of the same as we do when we meet at physical locations, but we're just trying to stay in touch with each other and help each other out with our businesses and our needs and so forth. And then on Thursdays, we're doing a little unique. We've opened it up to other chambers through the IRCA. IRCA is a consortium of includes Connecticut River Valley and several other chambers. And we opened it up, and it's now spawned into, we're doing some topics there as well, and a little bit of happy hour and a little bit of topics, and that's Thursday at 5 p.m. So those are our 3 sessions. And then we also have some special sessions or Zoom sessions that are offered occasionally, and the chamber will communicate those through all their channels as well. So I'm not sure, Mary Ellen, anything in particular coming up that we should know about that's not in the
No, I think we're all just trying to get back to normal, but there will definitely be more things, but right now, not this week. We don't have anything else scheduled.
All right, excellent. So I mean, the way this session will go, again, thank you so much, Dr. Brian and Dr. Joe, for being here. We're going to let them share with us on what's happening in their practices and their preparation, and then we'll open it up as well. And you know, as we go, if there's any questions, just raise your hand, and we'll let them both guide the discussion, and we'll also support them and ask any questions or share information from a client perspective, whether you're going to go to a dentist or a GI or any medical practice. I'm sure some of us have concerns, and we can express those and let the 2 wise doctors help us out here. So with that, Brian and Joe, I'm not sure if you're probably not planning on talking exactly at the same time, so I'll just turn it over to both of you and see where it goes from here.
Well, who'd like to go first?
Go ahead, Brian. Take the lead.
Sure. Well, very, very briefly, Mike, our dental experience in our dental office is not going to begin in our dental office. It's going to begin outside our dental office in the parking lot, where people will come up in their cars, park, and they'll call either Mary Lou or Dale that they're here, and then they will be called in. They'll be actually gone out to the car and gotten in, and they'll enter our office that way. This will minimize their time in our waiting room, and we do not want congregations to exist. Once they come into our waiting room, they'll immediately get their temperature taken. We have one of those mobile temperature takers that you've probably seen in the airports if you've done any flying recently, and then they'll be asked to do a health history update specific to the coronavirus. And the pen and the clipboard will be wiped down with a special disinfectant right away after that happens. There is a hand sanitizer out there for people to put on their hands before they enter my operatory. And if they are not wearing a mask, then we will offer to give them one that's free of charge. After that time, they will be ushered into one of our operatories where we have special PPE equipment that we'll be wearing now, specifically due to the coronavirus. And that's going to include a hair cover. It's going to include eye protection. It's going to include a special face shield and a specialized mask known as an N95 mask. And then over everything, we're going to put a surgical gown, which is disposable. And we will be wearing surgical scrubs. After each appointment, our operatories get wiped down with a special disinfectant called Optum Wipes that is specifically geared to kill bacteria and viruses, including the coronavirus. At the end of the day, all of our scrubs, anything that we wear in the operatory, will be put in a washer and dryer that we had installed into our office, so that anything that we wear in the operatory specific to patient treatment will never leave this office. Other things that we're planning on doing is we have ordered and installed special suction devices called Isolite system, whereby when we're working in the patient's mouth and generating an aerosol, there is a constant high volume evacuation system that exists to suck all that up. We'll also be staggering our appointments to make sure that not a lot of people are congregating and being in our office at the same time. And other things that we do, we spray down all our rugs with a disinfectant every day. Perhaps overkill, perhaps not, but we didn't want to take any chances here. Our patient's safety is our primary concern. And that about does it in a nutshell, Ski.
Excellent. You know, it's interesting, other than you're pretty much getting close to a full hazmat suit in your operation. Very similar to, my wife and I own a hair salon. And so very similar practices that that are part of our guidelines and procedures, from the client calling and waiting in the car. Our waiting room is closed, although we have 2 chairs set up there that will be used by employees for just to take a break and with their mask and face shield still on, but very, very similar. Well, I had one question for you, and surely you're going to hear from Joe as well and open up further. But on in a hair salon, and I know this is even probably as or more rigid in any type of medical practice, but we have certain certifications. So we have a disinfectant called barbicide. So every salon, to get a license, you have to be barbicide certified and apply all those principles. That's how we clean a lot of the tools. Now we're extending that out to the furniture and any touch points in the salon, whether it's the shampoo bowl, the chairs, and so forth. So what's the similarity? I think we just take for granted when we go to a dentist that when we sit down in the chair, all the tools have been disinfected. And so it's really no different, as you were just in these more challenging times. But can you just speak to that practice?
Sure. Well, any of our tools or instruments that we use, Mike, they don't get disinfected, they get sterilized in a special autoclave that we have in our office. As for disinfectant procedures, let's say on countertops and anything that we touch, pens, clipboards, door handles, we have a special hospital grade disinfectant called Optum. They're called Optum wipes. They're a medical grade disinfectant used in hospitals that, as I believe I said before, kills everything.
We also use a lot of barriers.
Yeah, and Dale just mentioned one other thing. We also use barriers for anything we touch on a regular basis, like our lights, our light handles, our X-ray dials. Everything has a barrier over it that's changed after every patient.
Yeah, thanks for sharing. I know even in the barbicide training, a hair salon only needs to go through the step of it's clean, sanitize, disinfect. The next step beyond that in the medical world is the sterilization. I think it's important. That's a great thing to communicate out to when you're communicating, reopening your practice, just letting everybody know the level that a dental practice goes to, because it just gives people more comfort to know that's being done.
Sure, Mike. And we are, in the realm of healthcare, we are really technically considered frontline practitioners for several reasons. We cannot treat our patients at a 6-foot social distance. We cannot treat patients with a mask on, as opposed to, let's say, an orthopedic surgeon that's examining a knee, or an ophthalmologist that's examining an ear. So our patients cannot wear masks, and depending on the procedure, we generate an aerosol. And it's well known that the most common transmission of this virus is by respiratory droplets.
Yes. All right. Well, thanks for sharing. I'll if there's a few questions for Dr. Brian, open that up, and then let Joe take over as well. Did anyone else have any other questions now, or you can surely hold them until the end as well? Okay. I don't see everybody here. All right, Joe, why don't you?
Well, thank you. Thank you for this opportunity. And you know, in thinking about it, and Dr. Brian did a great job, and many of the same things that he does, we do the same. Except with his practice as a dentist, he's really the aerosol is exposure all the time. As a gastroenterologist, I should say it's only half the time we have exposure on that end. Otherwise, it's the bottom end. But you know, in thinking about this and in going back, I guess I should really just take us back to where we were in like mid-March when this whole and I want to kind of take you through the process of what happened to our operation, where we were, where we went, and where we're going. When this all started, March 23rd, you know, we really shut down. That became, in most issues, that the patients and everybody stayed away from the practices. And we divided it up into 3 different phases, the way we looked at it. You know, our most important point was safety for our patients, safety for our staff, and also we really wanted to try to maintain our staff working throughout this. And we were able to get by the whole this whole situation so far without any furloughs. And it was really difficult. But it really took an entire team to kind of get through this process. And the way we kind of looked at it is we broke it up into 3 different phases. We looked at phase 1 as the pandemic. The pandemic is shut down immediately and transitioned to home. And many of our employees worked from home during that period of time. Phase 2, we called the plateau, keeping our head above water. And phase 3, which actually starts today, is this transition, you know, to recovery and beyond, and trying to see what we learned from this. Well, we learned initially that we made a complete transition, as opposed to dentistry. In gastroenterology, in most cases, we can actually transition to telemedicine. We had no telemedicine experience in our practice, and was able to, over the first week or 2, transition to a telemedicine practice. Now, our practice is big. Not only do we have our Glastonbury location, but we have 16 locations throughout the state. We have 7 endoscopy units, and we have about 450 employees. So this was a multifaceted approach that needed to be done around the state. And we were able to accomplish this, get it going. Our office practice became 10% of patients came in the office, and we employed strict screening, temperature checks, waiting in the parking lot, just like Dr. Bryan said, and just having patients come in. And as opposed to dentistry with masks, we were able in the office setting be able to have to get through those visits, limiting it to less than 15 or 20 minutes, and really approaching it in a safe way. The big issue during this period of transition, many people adopted to telemedicine. We had about 400 patients a day in all our practices coming for telemedicine, and maybe less than 20 actually came into the office. So that was the office practice during that plateau phase. Now, our endoscopy units, we didn't shut down completely. Many places around the country shut down completely, but we moved down to about 10%, which were really our essential urgent procedures that needed to be done. These weren't the screening colonoscopies. This wasn't the people that have had history of polyps before, some heartburn and reflux, but these were really the urgent endoscopies and colonoscopies. And we employed strict principles. We slowed our time by the procedure by a half. We did full patients and families. The family stayed in parking lots. The patient would come in, and then we would kind of escort it through the process. It was full gowns, face shields, masks, and also it was a N95 mask that we had to use. Most of the aerosolized issue is really when we do upper endoscopies. And with that, it was very, very strict approach in the room as far as the cleaning pre and the cleaning post, again, using all the medical disinfectants. We gotten through that process, and about a week or two ago, we began opening up to about a 50% speed in the endoscopy units, and patients have been coming back. We've been doing not only asking questions, but we've been testing every patient that comes for an endoscopy and a colonoscopy 4 days before the examination. And we get the results about 24 to 48 hours later, giving people the green light, whether to prep and come straight on in for the procedure. So this has been an extremely great safety bin. Not many states around the country are doing it. A lot of it are just employing screening. So this has really built up a lot of confidence. And even as of last week, we've had about 50% of our patients come back, which is all we really wanted, because we didn't want to take more of our time. We wanted to limit the patients in preoperative, post-operative recovery area, families in the waiting room, in the parking lot, and keep people out of the waiting room. So we've been very, very successful in doing that. Now, what was very interesting over this time has really been the patient perspective. There were many patients that were really concerned about going to doctor's offices, really concerned about going to the emergency rooms. With the telemedicine, with the advent of telemedicine and the adoption of telemedicine in our medical practice, now obviously this can't be done in dentistry, but I imagine there's lots of other primary care physicians that can be done, is many of the times we can triage by telephone because diarrhea is a very common thing that we see here in our GI practice. And it's one of the overlap symptoms when it comes to COVID. And very concerned about bringing everybody with diarrhea into the office. So it's through telemedicine, we were able to kind of go through and make a decision about laboratory testing appropriately, who needed to be tested, who needed to be come into the office, emergency room, because many patients feared the emergency room during this period of time, is no one really wanted to go to the emergency room. But what's very important to know, a couple of interesting facts that developed over the last couple of months that we've learned, is that the surgeons that we work with at the hospital report a 90% reduction in the amount of colon cancer elective surgeries compared to last year, the same 2-month period of time, which is a pretty concerning number, because what that sort of implies, either A, that the coronavirus cured colon cancer, which it probably didn't. What it probably implies is that people are just not seeking attention. So we have to be very in tune to not losing, patients through the crack, even seeking care. I imagine even in the dental community, there are people that tolerated things a lot longer. And where that became important is, although the number of elective cases for surgery went down significantly, when you look at people with appendices, acute appendicitis or cholecystitis, which is a gallbladder issue, is those numbers really didn't go down. But by the time the patients got to the emergency room, they were sort of complicated. It was a ruptured appendix. It was a perforated gallbladder. So the surgeons were doing much more emergency cases that were people that were really afraid to go to the emergency room. I think what's clear now is that we've learned a lot about the coronavirus. We're much more aggressive in testing, is that if emergency room visits are needed, people should not be afraid. It's real important because everyone, I can speak for Hartford Hospital, that every patient that's admitted is tested for coronavirus. The emergency room is split into corona at risk or corona not at risk. So it is relatively safe. It's COVID safe there in the emergency room. So if it's important, if patients really need the emergency room, they should. As far as the office goes, today we're entering phase 3, which is this transition period to recovery and beyond, we call it. This week, for 4 days, we actually have our staff coming back, but not the patients yet. The patients are going to probably start opening up a little more next Monday. But what we want to do practicing this week is, like I said, there's 450 employees in these 16 locations, is each of our site supervisors and managers are trying to determine social distancing, 6 feet, how many people can we have in the office, and the staff is getting used to things. They're tested every day, they're screened for temperature, checked every day, and the offices are really taken care of in a completely slower, cleaner way to just stay on top of it to make people safe. One of the issues and concerns we had was the potential of shutting down our kitchen facilities, which was a little bit devastating to know that people wouldn't have access to things like that. But they came up with very creative ways of limiting people that go through the kitchen area to a certain number based on the size of the location, cleaning everything that is touched afterwards to kind of give the staff that. So I think in summary, as we go forward, it's kind of important to know, these are some of the things that we're doing, and the patients need to understand that step by step, we're going to get out of this. We're coming back slowly. We're going to be in a better place in the end because we're going to be a little more sensitive to some of these things that we may have taken for granted. And now having telemedicine kind of added in gives us the ability to have another modality of taking care of our patients as well.
What happened?
Excellent, Joe. Thank you. Thanks for sharing. Very informative. I would say that between you and Brian, you've covered all sides of this topic, if you know what I mean. But hey, just a little morning humor. But thank you. That was really good, both of you. And with that, I'm just gonna pop around.
I have a question. For Joe, do you expect the telemed to stay in place and continue to even grow at this point?
Great question. So it depends on who you ask, and the question is also, what is the right thing? For years, we've been looking at the whole idea of telemedicine, and one of the resistance points that we have had is really the insurance industry as far as regulations and not allowing that. I got to give credit to the insurance industry because when this pandemic happened, immediately from Medicare right down the line, every insurance company allowed this, and it has been a tremendous boon. And patients, not everyone should be a telemedicine visit, but I can tell you, when you think about it, this is what I talk about. We talk about this phase 3, the transformation, recovery and beyond. What did we learn from this? Well, telemedicine is, to me, the key thing here. And you asked a great question, Mary Ellen, is where this is all going to be. And I think this is why it's important that the patients understand the importance and value of telemedicine. Obviously, for a dentist or for someone with an acute GI problem with abdominal pain that needs to be evaluated, it's not really the most appropriate thing, a new patient visit. But I have many patients, one of my specialties is inflammatory bowel disease. And many of these patients are doing really well, but 2-3 times a year, we should touch base with them just to see how they're doing, make sure things are all in order. And to have a telemedicine and those follow-up visits is fantastic, because if you think about the loss of productivity from work, if a visit takes about 15-20 minutes in the office, they're leaving a half hour before, they're waiting a half hour in the waiting room, they come see me for half an hour to get back. It's a 2 to 3 hour process. There are many employees that are losing maybe potentially a half a day of work because of this. Here, literally, it can take just 15 minutes during a lunch break. I've had patients from manufacturing companies that inflammatory bowel disease, I can't get into the office in over a year. And here was an opportunity to literally take their lunch break, go into their truck, pull out a sandwich and a drink and kind of call me on their iPhone and do the visit. And we picked up a few things that were kind of missed over the last year. So in summary, I think it is a fantastic way, but we need to continue to put pressure on the insurance carriers, because many of these insurance carriers are just giving us a timeline that when this all dies down in a month or two, they're going to go back to the way it was. And I think as employers, and as patients, we kind of need to say, you know what, there may be a role of having this in some place. So let's hope that this continues, Mary Ellen.
Thanks, Joe.
Excellent, thanks. Any other questions for Joe and or Brian? Comments, questions? Looking around, I can't see a few of you, so chime in on the phone if you're on.
You know, carrying the question I have actually for everyone out there is telemedicine experience. I think carrying on what Mary Ellen is saying, has anyone out there had any experience over the last couple of months with telemedicine, either themselves, their family, friends, positives, negatives, or anything about that?
I would tell you my mother had an experience with it. So she's 87.
Wow.
And it really bothered her that she was being charged for a medical visit without seeing a doctor.
Right.
So it could be the generation,
Yes.
but it's a
So
great experience.
Yes, I would say, Mary Ellen, clearly, I could definitely divide it up to generational as well, because as upset as your mom may have been because of not having that, being in the office and getting dressed up to see the doctor and having that experience, I have equally people on the millennials on the other side who will never want to come and see me. are so happy about it. And that's why I think it can't be abused. It has to be tailored for the right setting. Now, obviously, during this period of time, the right setting, even for your 87-year-old mother, was to do it by telemedicine. Right. But that's something that shouldn't be kind of pushed going forward, I would agree.
So there are concerns about actually the insurance coverage. And we've even, I know you can buy ancillary products that will cover be above and beyond what your own insurance company will cover. And I'm just wondering if that's going to be a new trend. It'll be interesting to see where it goes.
Good topic. I'm thinking of my daughter had a little telemedicine because she had a baby April 1st. She was due on the 16th, I think, and had one visit with her doctor, but then had some follow-up telecalls and ended up admitted early to the hospital and ended up having her baby. She had to have it early just due to some complications. It actually ended up being wonderful because she spent 4 days, but she got out of Hartford Hospital in early April versus, when everything peaked about the time she was due. So her little telemedicine call helped her to get into the hospital and move the pregnancy along so she can have her baby and get home. And everybody made it through safe and sound, and it's a wonderful experience. Yes, any final, well, what I'd like to have you share. Oh, sorry.
Well, and it's really not related to either doctor, but it's medically related. I would love to go and give blood, and I'm concerned about doing that. What do you, and I know it's not your area, but I just can't figure how they could sanitize everything. And so I haven't gone to do it, and I feel remiss and would really like to do it. I just anybody's thoughts on that.
My only recommendation, I don't know any of the specific details, but that's an obvious concern that a lot of people who are regular blood donors, I just would probably refer you to the American Red Cross and find out that they must have some sort of standards or guidelines to allow that to happen. To recommend what they would recommend for you. And I'm sure that if they're going to have a sponsored blood draw location, they're going to have to make that as safe as possible and be able to sterilize everything they need.
I feel much more comfortable going into a doctor's office when they're moving everything in off of trucks and they're setting it up. And but the blood donations are so important. So thanks. I will do that.
Well, I went and gave blood before masks were required and things like that because I do have one of those bloods that everybody's always seeking. And I have a father that is alive because of blood donation. So I've always been, wanting to give. But it freaked me out. But I think that with the social distancing and the masks, I think I went too early on that I think I would feel a little safer now and not, but I think it is a good thing to do. But you just, and I think everywhere, everybody has a different level of comfort and you've just got to be your own advocate and you've got to, if you don't feel comfortable, don't stay, don't, but I think for the most part, I think it's a safe experience. I also had a conferencing with my doctor, and because I have a great relationship with my doctor, I felt very comfortable because I had gone in and gotten my blood work done ahead of time. He called me right at the specific time that they said he would call, and we were on the phone for a good half hour going through symptoms. But would I want that continually all year? No, I obviously would want him to look at me and, and do the vitals. But I think in between and given this time of year, it was the right thing to do.
But Diane, that's a perfect example. I mean, for, your routine, for your physical exam, you wouldn't want that. And it's also that you've had that, or as a new patient, if we see a new patient consult, that makes me uncomfortable. I wouldn't want that either. But as someone that you have a relationship with your primary care physician, to be able to do that is fantastic. And that's where telemedicine should not be a substitution, which it actually was during this period of time. It's kind of morphed into something that is more a complementary way of doing it with the regular office visit. And I think that's where it's going to hit the sweet spot.
Before we finish up, Brian, I've known Joe for years, and I don't know if everybody knows both of you. I did take a quick pop out to your website to check it out and see a little more about who you are, but just share a little bit about your practice and yourself, and get your chamber time in for being here. So I'd like you to, just like you to learn a little more about you and your practice, and then Joe, you as well. We really do care about our chamber members, and we thank you so much for being here. But now it's your turn to share more.
Sure. Okay. First of all, at times, Mike, you're breaking up. Can everybody hear me?
Yes.
Okay. Well, I've been in my Glastonbury office here since 1984. With my wife, Dale, we grew up in Glastonbury. We're actually high school sweethearts. We graduated from GHS in 1970, dating myself a little bit. But we are a general practice facility. We treat families. We do primary care and some specialized dentistry, extractions, more complex restorative dentistry, some root canals, some gum work. So we kind of run the gamut here, and hygienists. And I just want to briefly add one thing: how delighted we are to be back in Glastonbury, the just most wonderful town in Connecticut. Thank you very much, Mike.
Yes, thank you. And I know that Brian's located down in South Glastonbury, a 1-minute walk from Sayulita. And we actually have, other than our education and skills, we have a lot in common, because my wife and I also met in high school. We both graduated from different high school in Colchester, and we both have 2 daughters and a couple grandchildren as well. So I just didn't take my education as far as you, Brian. So I ended up working for Pratt Whitney for 30 years, and now I own a hair salon. A little different track. And Joe, tell us a little more about yourself, now that I just stole some time and got my free commercial in.
So my wife is my college sweetheart, not my high school sweetheart. So we only go back 40 years. I'm a Bronx boy, everything New York City, until I graduated medical school in 1987 and wanted to get a little bit out of there, and came up to initially West Hartford for a few years until one of my partners, I went into practice in 1993. One of my partners said, well, what are you doing in West Hartford? Glastonbury is a place to be. And I ended up moving here 25 years ago and have loved it, where I have raised 3 children through the Glastonbury system. One of my daughters has an 18-month-old, and another one coming in August. So it's very, very exciting to have those grandchildren. That really kind of kicks it up a little bit. But my practice here in Glastonbury has been since 2009. When we expanded the practice, we're a GI practice, and as they developed the property over on Western Boulevard, we took over one of the medical complexes and put in an ambulatory surgical center. We do colonoscopies and endoscopies, and also my main office is here. And the practice, which initially, when that partner who's convinced me to come to Glastonbury was me, him, 2.5 employees, we now have 60 physicians, 30 advanced practitioners, 16 practices, 7 ambulatory centers throughout the state. And it's become a really busy operation, but we try to kind of bring it down, to the patient relationship. And one of my big things in the practice is this whole focus, even before this, on wellness and health. And it is with that, I've developed my relationship with the chamber as far as the Wellness Council, and trying to work with you guys and come up with some initiatives to not only take care of sick patients, but to bring health and wellness to our community in all aspects. Thanks for this opportunity to do this as well.
Yeah, wonderful. Good learning a little more about you and both of you. And I would just say, stay engaged in the chamber, because we all benefit from having good people like both of you. So thank you so much for doing this and sharing.
Well, thank you.
Yeah, you're more than welcome, Mike.
What's that, Brian?
You're more than welcome.
Yes, thank you. Any other comments? I see a lot of smiling faces. Diane's like, oh, great. I just heard how old some of these old guys are. She's starting to feel a lot younger now. Great, big smile. Katie, I haven't met. I think I have. And now I see Big James is on board. And by the way, Joe, somebody has chimed in a little private message that you look a little like Bill Lambier.
Who's it?
I got a little private message that says, Dr. Joe looks like Bill Lambier, the basketball player.
Pull that up.
These are famous. Any other comments before we take on this day?
Yeah, Mike, just one quick thing, and maybe Joe can jump in here, is addressing the treatments, the various treatments, the vaccines, other agents that are perhaps coming online very, very soon to combat this virus.
Great question, Brian. And boy, never in my career have I ever been, maybe HIV may have been in another situation like this. I guess that's probably the last time we thought of this, where we were attacked by a virus that we've had no experience with and didn't know how to handle. And boy, you can see some of the shotgun craziness that was thrown at everything. And it was not for malintent. It was really that no one really knew when they were grabbing. And, as scientists and physicians, we look at double-blind, placebo-controlled studies that could take years to develop. Here, we didn't have that opportunity and we didn't have that chance. So even some simple things, we were just, we learned through our experience at Hartford Hospital that, the need for ventilators, and many people on ventilators were dying. Well, one of the things that we learned is it's probably not a good idea to put people on ventilators, and anything that you can do to avoid that the ventilator itself and the positive pressure of the ventilator itself might have made things worse. So that was an interesting fact. And once we realized that, we started really avoiding ventilators as much as we can, and the patients have done really, really well. As far as, it's too early to report how the studies are coming out. I would probably say, and again, this is my opinion, there's definitely no consensus here. There's no scientific proof to this. But if I had a bet on this today, or give you at least what we're looking at right now today on, May 26th, 2020, is it does seem like the whole hydrochloroquine idea, which was a great thing that came out of a great study that was a study out of France, is really fading out. It's probably not meant to be. Where we're seeing a significant amount of help has been with the use of the antibody infusions. And at Hartford, we've done over 100 patients, and this is where it comes to, you talk about donating patients that have had COVID, that developed the antibodies to high enough levels, they can donate their antibodies, and infusing those antibodies seems like it makes a difference. And then it does look like the early data on some of the antivirals directly attacking the virus, the remdesivir, seems to be making a difference. But this is where we are now. It appears that we're not going to be out of the woods until we are able to get a vaccine that can inoculate the entire population, which even if a vaccine is formed and created, we can't be sure that things may not change or migrate with the virus and mutate to a point that the vaccine may not be as perfect. So I don't want to be pessimistic about that, because I want to be optimistic in that we're making progress. But I think the difficult thing that we face right now is, as a community and as a society, is where do we go from here? The fact that the data is still not all out there and we don't really know, and we've had an unbelievable, unprecedented experience over these last 3 months, something that maybe 100 years ago during the Spanish flu, and then we never had the transmission, the media, the way that this old social media, where it transmits around. So this is really a very unusual situation. So we gotta, I guess the question is there is no right or wrong. And if anyone who approaches this, I think the only thing that's wrong is approaching this from a purist aspect. And when I say a purist aspect, I mean, we need to be locked down away from society until a vaccine is invented and everyone is inoculated on one side. And then on the other side is, you know what, no worse than the flu, it's over, just go out there and don't worry about anything. I think those are both big mistakes. Where we have to decide is in the middle. And I think it's a little bit different where we live, what state, part of the states. And this is where it's very, very important that the community really gets involved in understanding this and being respectful of how these guidelines are created and how we go step by step. I think, it's important when we look back at, the things that we went through, we learned from our experience with our family, our friends, what we had, what we didn't have. And, I want to leave almost with a quote that my wife and I'll screw this up, but put in the laundry room. And, she has this little quote there from this that says, when we think about what we miss and what we want to go back to, maybe we should think about what we really want to go back to and decide what was important and what was not, and maybe give us some free time and more time to think differently going forward. So as we rush to go back to what we feel we lost, maybe we should think about what we're rushing to get back to, I guess is the point.
That's great. I don't think you screwed that up.
No.
And I'll tell you, I will take your advice, because I'm going to step outside. I'm looking out my window at Lake Terramuggus, and I'm going to go smack in the middle of it, which is what you recommended, stay in the middle. And I'm going to go take my kayak and just hang out there, because it's the safest place, second safest place in the world than being up in the mountains in New Hampshire. So I want to thank you both again. How fortunate the rest of us are for being smart and getting on this call. So I just say, join us again tomorrow. We're going to do developing some relationships. So we're going to take it to the next level. So just step into a call at noon tomorrow if you're around. And just a quick update, we've taken a pause from the Thursday sessions to breathe a little. So we weren't getting a lot of traction from all other chambers participating. So we don't want to overwhelm everybody. So right now we're doing Tuesdays and Wednesdays. Tuesday morning, 9, and Wednesday at noon. And with that, I just say thank you again.
Thank you very much.
Yes. Mary Ellen?
Thank you very much. We're very grateful for all of you, but especially Dr. Joe and Dr. Brian. Thank you very much. And thank you for serving our communities and for keeping us healthy and safe. We appreciate you both.
It was our pleasure.
Have a great
Bye-bye.
You ever get a Zoom standing ovation? There you go.
Look at that.
There are a lot of firsts.